In this video, we'll demonstrate the repair of an Achilles tendon tear in the foot using a surgical device and sutures. The Achilles tendon is a strong cord-like structure that connects your calf muscles to the heel bone and is used in walking, running, and jumping. The Achilles tendon can tear due to overstretching of the tendon. It commonly occurs in people playing recreational sports. The Achilles tendon is repaired by the use of surgical sutures. First, the surgeon makes a surgical cut in the back of the lower leg. The top part of the Achilles tendon is grasped. With the help of a surgical device, multiple sutures are inserted through the top part of the tendon. After removing the surgical device, the sutures are organized and stitched in a particular pattern. This creates a strong stitch on the top part of the tendon. The surgeon then places the surgical device on the bottom part of the Achilles tendon and repeats the same suture pattern. Then the top and bottom sutures are tied together in a specific pattern, closing the tear in the Achilles tendon. This completes the repair.
The postoperative management of an Achilles tendon repair can affect the speed of rehabilitation. The rehabilitation program following an Achilles tendon repair begins about 2 to 6 weeks postoperatively. This is because the tendon is weak during the first 6 weeks of healing and then slowly increase in strength over the next 6 weeks to a year. Weight bearing is incrementally progressed and guided by close communication with the surgeon. The patient will be advanced using a criterion based on functional progression. Time to return to sport ranges from 4 to 6 months based on the sport type, with contact sports requiring more extended periods. The first phase of rehab, weeks 1 through 6 following an Achilles tendon repair, is dedicated towards protection and healing. Goals for this stage are protect healing, control edema and pain, minimize scar formation, improve range of motion of dorsiflexion to neutral. Proximal hip and knee strengthening exercises are initiated to increase proximal lower extremity strength in all planes. Protected weight bearing, as directed by the surgeon, is significant during the first postoperative phase. It promotes tendon healing and strength while preventing the adverse effects of immobilization like muscle atrophy, joint stiffness, adhesion formation, and DVT. The second rehab phase, weeks 6 to 12, will usually signify a change in weight bearing status, increasing mobilization of the involved leg and gentle strengthening. The patient is progressed to full weight bearing in a cam boot using crutches and then advanced to full weight bearing in a cam boot without crutches. The use of a heel lift can also be used to help make the transition to more dorsiflexion. The final phase of rehab may take anywhere from 7 months to a year, depending on the patient's desired goals and activity levels. During this phase, the remaining strength and flexibility deficits continue to be addressed. Care needs to be taken that the patient or athlete has a good strength base, range of motion, and flexibility required to participate in high-level activities such as plyometrics and sport-specific drills. We also want the patients to exude confidence demonstrated by a lack of apprehension before returning to their sport. In this phase, sport-specific drills, advanced plyometrics, and agility exercises are used to reproduce the desired sport's functional demands. Plyometric drills may be progressed in this phase to more demanding single leg activities like single leg hops, single leg side to side jumps, and quadrant jumping. Functional testing such as vertical jump tests and broad jumps tests can determine the patient's ability to produce power. It's desired that the patient demonstrate greater than 90% limb symmetry and has clearance from the surgeon before returning to sport.